Hello and welcome to the Stripe Stroke Interprofessional Education series. In these sections, you will be learning about post-stroke cognitive impairment screening and management. My name is Linda Lim, Advanced Practice Nurse from National Neuroscience Institute, NNI. Together with me, I am happy to have Dr. Kinja Doshi, Principal Clinical Psychologist from Singapore General Hospital, SGH. For today's objective, we would like to share the cognitive domains, spectrum of impairment, impact on cognitions and functional recovery, screening tools, and the management. We will be dividing these sections into two parts, and we will be moving into cognitive impairment as our first discussions. In the conscious states of mind, our cognitive domains reflects as follows. Attention domains deal with the ability to focus awareness on a given stimulus or task, to concentrate on the stimulus or task long enough to accomplish a goal, and to make shift awareness if appropriate. This ability varies by individual and may be impaired to the point of becoming a formal attention deficit disorder. Problems in these domains can make focus, searching, and interactive difficult. Learning and memory comprises of visual, verbal, and motor memories. Memory can be very brief, short terms, or long terms. Learning is another dimension here and can be measured in terms of free or acute recall, as well as by various forms of recognitions or cueing. Problems in this domain can affect recall from section to sections in the verbal modes. The lack of attention can hinder learning and memory domains too. Executive functions domains deal with a variety of higher order functions like planning, conceptualizing, organizing, evaluating, largely concerns with the working of the frontal lobes, to the last to evolve and develop in the human brains. Difficulties in this domain can be of many kinds and can make inner searchings and insight particularly difficult. Language domains. Language skills of various types are covered by these domains. They are typically associated with the left or dominant cerebral hemisphere. Both written or oral, they consist of one's ability to comprehend, repeat, and express in these modes, in addition to the finding words and names quickly by category or sound. Problems in this area can make communication difficult during day-to-day or even during therapies. Visuospatial domains deal with the ability to make sense of the visual world like shapes, angles, large versus details, the meanings of form, and to produce what's seen. Problems here can affect a person's ability to conceptualize complex ideas and relationships, and leads to an over-reliance on verbal expressions. Social-emotional processing. Emotions play an important role in recognitions. Depression modes interfere with attentions and concentrations and processing speeds. Poor attentions and concentrations and processing speeds interfere with the performance in other cognitive domains such as memory and executive functions. Post-stroke cognitive impairment, or PSCI, is defined as failure in any cognitive domains after stroke, like in the domains of executive functions, memories, language, visuospatial ability, visual constructional ability, or global cognitive function. It is acknowledged that appropriate 2/3 of stroke patients develop some kind of cognitive decline, be it cognitive impairment or dementia. Therefore, PSCI screening is an important part in the recovery phase. Cognitive impairment can affect anyone. It is not an illness but means that a person may be troubled with things like memory or paying attention. This can be temporary or permanent and will affect what the person can understand and how they relate to others and interpret the environments. This can be mild or severe or anything in between. Cognitive impairment can come and goes. Delirium is an acute disturbance of consciousness, attention, and conditions that tend to fluctuate during the course of the day. It is usually a treatable medical emergency, and it is important to treat its underlying causes. Short-term or reversible cognitive impairment includes infections such as a urinary tract infections or pneumonia, vitamins deficiency, dehydrations, or even reactions to medications. Some causes of long-term or permanent cognitive impairment include dementia, stroke, brain injury. Dementia is a chronic or permanent disorder of the mental processes caused by brain disease or injury and marked by memory disorder, personality changes, and impaired reasoning. This decline in mental ability is severe enough to interfere with daily life and thus causing an individual to be not functioning at work, in the community, or even at home. In this group, the decline can be verified by standard cognitive tests. There's another spectrum of cognitive impairment, which is known as mild cognitive impairment, MCI for short, and subjective cognitive impairment, SCIs for short. MCI refers to a condition in which there's a decline in one's usual cognitive ability, but not to the extent that is obvious in daily living activities like banking, driving, managing medications, and taking care of usual responsibilities. In this group, the decline can sometimes be verified by standard cognitive tests. MCI has recently become a concern to medical practitioners because it can be a sign of progressive decline to a stage of dementia. However, not everyone with MCI will develop dementia, as the conversion rate is around 16% annually, which means out of 100% with MCI, 16 could be converted to dementia. SCI is when a person reports a worsening of their thinking ability, including memories, but the decline cannot be verified by standard cognitive tests. There is increasing evidence that subjective cognitive decline, the self-reported perception of memory or cognition problem, is a potentially valid early clinical marker of brains and cognitive changes. How do we then assess individuals for their cognition states? Cognitive screening is the initial step. It is usually brief and contains essential items to assess and evaluate cognitive domains. However, if required to, the cognitive assessment can be into depth sections. On a side note, there are some important factors to consider when doing cognitive assessments as they may affect the process and results. Time of assessment, duration since stroke incidents. Do take notes of the days after stroke event and the type and severity of stroke, and this could be a hinder for a person to perform his or her best during assessment. Post-stroke recovering period. Presence of purely physical problems can also interfere with interpretation if not properly noted. For example, patient may be physically unable to hear or read instructions properly or may have a motor deficit that affects writing and drawing skills. Shock, as he or she has yet gotten over the stroke diagnosis, thus may also affect the assessment. The venue of assessment is also important as the ideal environment is to have a quiet place during assessment period. Places like bedside, assessment room, or even in the clinic room. Last but not least, the experience of the assessor. The assessor must be confident and know how to administer and interpret the cognitive test. Many a time, assessors are not or even went through a proper training to do cognitive testing. Cognitive assessment can be largely divided into global assessment and domain-specific assessment. For today's discussion, we will touch on global assessment, which comprises of Mini Mental State Assessment, MMSE for short, and Montreal Cognitive Assessment, MOCA for short. The MMSE was developed in 1975 by Dr. M. Frosty et al. It is a brief 30-point questionnaire commonly used to screen for dementia. It is also used to estimate the severity of cognitive impairment at a given point in time and to follow the course of cognitive changes in an individual over time. MSE is one of the effective ways to document an individual response to treatment, and it takes about 7 to 8 minutes to administer. It's not expensive, with 11 simple questions or tasks. 7 cognitive domains include orientation to time, orientations to place, registrations of 3 words, attentions and calculations, recall of 3 words, language, and visual constructions. This is useful instruments to screen for moderate to severe cognitive deficit in stroke patients and to screen patients on more detailed neuropsychological assessment. MSE of less than 27 1 month after stroke is related to poor cognitive performance in the long run. Patients with low baseline MMSE score deteriorated more often than patients with high scores. MMSE cannot be used to predict whether an individual patient will recover or deteriorate. The following 3 cutoff values can be employed to classify the severity of cognitive impairment. The points of 24 to 30 will indicate no cognitive impairment. The point of 18 to 23 will classify one will have mild cognitive impairment, and less than 17 will consider as severe cognitive impairment. The Montreal Cognitive Assessment, also known as MoCA, was designed as a rapid screening instrument for mild cognitive impairment. It assesses different cognitive domains like attention and concentrations, executive functions, memories, language, visual constructional skills, conceptual thinking, calculations, and orientations. It was created in 1996 by Dr. Nazarine in Montreal, Quebec. MoCA test is a one-page 30-point test and can be administered in appropriate 10 minutes. The test and administration instructions are available for clinicians online. The test is available in 46 languages and dialects. MoCA score range between 0 and 30. A score of 26 or over is considered to be normal. To better adjust the MoCA for lower educated patients, 1 point should be added to the total MoCA score for subjects with less than 6 years of education.
Reducing the impact of post-stroke cognitive impairment is an important goal for many stroke survivors and their caregivers. Cognition is important for recovery in other neurological domains, as cognitive impairments can reduce a person's ability to understand task instructions, to plan and initiate self-directed activities, and to solve problems. Hence, post-stroke cognitive impairment and reducing it is important for the entire rehabilitation and recovery of a stroke survivor. Cognitive rehabilitation is a systematic, functionally oriented service of therapeutic cognitive strategies and an understanding of the person's behavioral deficits that are directed to achieve functional change by reinforcing, strengthening, or establishing previously learned patterns of behavior, or by establishing new patterns of cognitive activity or mechanisms to compensate for impaired neurological systems. Approaches to improving cognitive outcome after stroke can be classified as either compensatory or restorative. Compensatory approaches involve adapting the external environment to address altered cognitive abilities. For example, stroke survivors with memory difficulties are made to set an alarm to cue them to review their plans for the day, which they wrote down in a book. Compensatory approaches can also consist of internally generated strategies. For example, stroke survivors who have reduced speed of processing information were taught to compensate for mental slowness by reorganizing their tasks to accommodate those with a time pressure component. Restorative approaches, on the other hand, aim to restore the lost function to the survivor. These approaches are based on the realization that neuroplasticity is possible throughout the lifespan and can be influenced by training. However, such an approach has only been shown to be effective for the treatment of focal cortical strokes. When engaging in cognitive rehabilitation, we must first identify the cognitive abilities of the survivor and employ strategies that meet them at those abilities. We must also acknowledge the motivation and emotional state of the survivor as it impacts their willingness and ability to process and learn the skills and strategies being taught to them. Second, any skill taught must be specific to the needs of the stroke survivor and be presented in an overt manner. The outcome of the skill must be measurable and achievable within a realistic time frame. During training, survivors have an opportunity to self-monitor their ability and learn to adapt the skills to meet their various needs and goals. Eventually, a survivor is successful in learning these skills when they can generalize its application and internalize its use to meet their personal everyday goals. Whatever the mix of training, be it compensation or restoration, cognitive rehabilitation needs to be systematic, structured, and repetitive, according to the individual's needs. As you can see on this slide, there are 3 levels of cognitive rehabilitation, and each level must meet the survivor at their cognitive ability, motivation, and emotional status. So depending on the cognitive ability, motivation, and emotional status of the survivor, one can provide training to rehabilitate the cognitive function, and with those who have lower ability, teach compensatory mechanisms to adapt to the cognitive difficulties, or, at the lowest level of ability, modify the tasks and environment to accommodate the survivor's loss of functional ability due to cognitive impairment. Where possible, we should achieve to meet the survivor where they are at and offer them an opportunity to be as independent as possible in doing their day-to-day tasks.
The take-home message for today's sections are: higher cortical assessment, though subjective, gives an important insight into initial diagnosis of cognitive ability of a stroke survivor. Cognitive rehabilitations need to be tailored to the survivor's ability and personal needs to promote their functional independence.